welcome to the October 25 Curious Cases webinar. So, my name is Gilad Borisovsky, and I'm an attending at Beth Israel Deaconess Medical Center in Boston. These webinars are meant to be informal and interactive, and I'm showing you cases, so please feel free to respond to my questions. And of course, if you have any questions, you can answer. And remember, this is exactly the place to look at cases. You don't have to know everything, but this is where we are learning. So it's exactly the purpose of this webinar. Okay, so I'm going to share my screen, and then we can start. Okay. So I hope everybody can see my screen. So let's start with the first case. So the first case is a young woman who is coming with shortness of breath. And we get the radiograph. So what is the important finding on this radiograph? What stands out to you? Anybody?
Heart.
I'm sorry?
Big heart.
Yep,
Yeah.
I agree. Okay, so we have, and in a medical language, we can say we have cardiomegaly. Okay, so you're absolutely correct. So what do you think it could stem from? Well, why does she have a cardiomegaly? She's a young woman. She's not supposed to have any. An idea? Anybody? All right, let's try to think about it. So basically, we can think about cardiomegaly as stemming from either the heart itself or is coming from the envelope of the heart, meaning the pericardium. So this could be either. What do you think could happen here? Is it coming from the heart itself, or is it from the pericardium? Anybody? Let's look at the lines. So basically, if you look at the left-hand border, we see that there's a little bit of elevation of the right-hand border right here. You see that it looks like it's a little bit elevated. So I would suggest that it could be the pericardium. Let's see what we have on the next slide. So what would be the next step? What kind of an examination would you want to obtain? Do you want cardiac MR? Do you want dedicated coronary CTA? Do you want echocardiography, or do you want to go straight into the pericardium and do pericardial synthesis? What would be the good thing for you? Anybody?
Echo.
So the first study is always echocardiography because we can get quite a lot of information about the heart itself, and especially if we suspect a pericardial effusion, it will evaluate for that, and of course for possible tamponade. Because once you say pericardial effusion, the next thing you have to answer is whether we have any concern for tamponade. Which we usually cannot see on imaging as cardiac MRI unless that there is also a functional component. On cardiac MRI you can sometimes have, but Again, conduct amount is before the evaluation. It's usually not for the primary evaluation. So usually echocardiography is the correct answer. But we got the surprise, we got the city. Okay. So I'm showing you a city, and I apologize. I don't know why all the videos are upside down, but there's something here. And who wants to see what happens in the heart? And if you have any idea, anybody an idea? I'm showing it again. Yeah. Anybody has any idea? Showing it again, and I will stop at the specific location. Okay, what do we see here? We see something that looks bizarre, right? It's hyperdense, and maybe it has some calcifications in the periphery. And on top of it, we have a pericardial effusion. But if you look at that, the pericardial effusion is pretty much small. So we have a finding that is calcified here, hyperdense calcified. So if we go to the next slide, so it's pericardial cyst with calcifications. Now, when you think about a finding that is in the pericardium is cystic with calcification, what kind of a diagnosis comes into your mind? Anybody? Okay, so this woman had a pericardial hydatidis, which is we can say that cardiac involvement of by hydatidis is very uncommon. And if we have any 60% of those cases will involve the left ventricle and only 10% will involve the pericardium. Symptoms are always depend on the size and location of the cyst. And again, as I said, it's an extremely uncommon case, and we saw it recently in our institution. And usually, echocardiography, although it's the first modality to evaluate the pericardium and heart, is usually insufficient for accurate characterization, for which we need CT and MR. And usually, CT is best for detection of word calcifications, and it will show the heterogeneous mass. Usually, there is no enhancement because enhancement would need some blood supply into that finding, and usually blood supply, there's no blood supply because it's an infectious finding. MR is better for anatomical localization, and then can show the internal and external components of the cyst. And usually the wall will be hyperintense. And if you think about it, because the wall usually has calcifications, it will be hyperintense on MR. Okay, and that's how it looks on MR. You see, this is the finding right here. I'm gonna show you this one. You see, this is the finding. Okay, that was the cool case, right? Let's go forward. We have a case number two, which the patient came for within cardiac CT for TAVR evaluation. And we have a finding that they want us to characterize. So let's see what the finding is. And again, all the videos are upside down. I don't know why. So I'm showing you one time, and then I will show you again. Showing you again, and please, can somebody say what they think it could be? So the options are left atrial hyperdensity, left atrial appendage hypodensity, left atrial dissection, or no particular finding. Anyone? Come on, guys. Not so difficult. This is a really simple case. Okay, let's see. So, what is this finding? Where is it located? And where could it be? I'm gonna stop the video and bring you to the exact image. So where is it? So let's see. I know the images are upside down, but this is the left atrium. Okay, as you can see, this is the order left atrium. We can see here also the pulmonary artery, the main, and the tributaries. So this is the left atrial appendage. So it means that we have a hyperdensity in the left atrial appendage. So this, 1 second. So this is the correct answer. Now, what is the meaning of left atrial appendage hyperdensity, and what would be the next step? Uh, a Option number one is mixing, no additional action needed. Thrombus, you need a cut to remove it. Thrombus anticoagulation, indeterminate, delayed phase needed, or TE. What do you think, guys? So the correct answer is indeterminate. Because the reason is that once we see the hyperdensity, and I'm going to bring you back to the video, so you can see that it's not completely hyperdense. I just want to bring you to this point. So you see there's some enhancement here. So probably it could be also mixing effect because if we think about it, sometimes in some people we have a phenomenon that is called slow flow. Slow flow means that there's slow mixing of blood inside the left atrial appendage. And I have to say that some cardiologists do anticoagulate for this condition because it does predispose for development of clots and systemic embolization. So some cardiologists are of the um, uh, they go to the worst and they anticoagulate these patients. But we don't know definitively if there's a thrombus here or the mixing. So that's why we need the delayed phase. And let's see if we have the delayed phase. Let's see what happens. So the delayed phase usually is obtained, especially in our institution, approximately 30 seconds after the first phase. And here you can see that the left atrial appendage has completely opacified. So that means we are dealing with a mixing artifact. So let's see if we have another slide about that. So left atrial appendage thrombosis, the main risk factor is anticoagulation, especially with the greater proportion of Asian population. And usually it's indeterminate. It could be either thrombus or slow flow stasis. And we always need, according to the current guidelines, we need a delayed phase or TE to exclude the thrombus. Usually transthoracic echocardiography is not enough to exclude that because if you think about it, the left lateral appendage is a very posterior structure, so it can be difficult for a transthoracic echo to visualize it. So you really need to do it from the esophagus, which is right behind the left lateral appendage, and it's much more sensitive. Okay, let's go to the next case. So next case is again a patient coming for evaluation for TAVR, and we can see that there is some vascular finding. Does anybody notice where the finding is? It's very subtle, very subtle. I'm showing you again. Did anybody notice what it is? So I'm gonna show you again. So if you look carefully, and you'll have to believe me that this is the left side, this is the right side, and this is some line here. You see the line? So we have a few options. It could be a dissection, could be a thrombus, could be fenestration, or no particular finding. I'll give you a moment to consider which of the option is more viable. So that is a fenestration, and I'll tell you why. So this is a different scan. So this is the scan on the corona. And I'll tell you why I think it's a fenestration and not a dissection, even though it could look similar. So if you notice on the corona, you see that the line doesn't go all the way from wall to wall, unlike on the axial. So it looks like it divides the lumen of the vessel of the femoral artery. It divides it into two similar vessels with a similar enhancement. Usually, when you talk about the dissection, the false lumen is supposed to enhance to a lesser degree compared with the true lumen. So that's why I think it's a fenestration. And if we talk about left femoral artery fenestration, so usually it is done either as a repair of a iatrogenic dissection, or it could be a congenital anomaly, which is actually quite rare. And usually what happens is that the vessel is divided into two separate channels, and they rejoin subsequently, as we see in this case. So that is how you notice it. Sometimes it's difficult to figure out, but that's how I think, and that's my thinking when I try to figure out which option is valid. Next case is a routine follow-up after surgery. So let's see what the finding is. I'm showing you again. I'm showing you again. Okay, so I'm gonna bring you close to the finding. So let's see. So as you probably remember in the anatomy, so this is main pulmonary artery in these tributaries. And we can see that the patient probably underwent some cardiac surgery, maybe valve replacement, maybe repair of the ascending aorta. I think the latter is a more viable option. And we can say that there's something weird here. You see that? Right at the root of aorta. So what do we think it is? The option down a dissection of the ascending aorta, aneurysm at the root of aorta, septal aneurysm, or no particular findings. So this is probably not viable because we do see something that is not supposed to be there. So it looks like we have an aneurysm of the root of aorta, and I'm gonna show you exactly how it looks like. So you see that there was a repair of the aortic ascending aorta, and at some point here, you can see that there's an aneurysm because there's a collection of contrast right here. And let's get some information about the post-surgical aortic root aneurysm. It is a rare complication, and it usually happens at the graft anastomosis sites. We usually have to, we need 3 phases for diagnosis, and I'll show you why. Because what happens is, if you have an aneurysm here, so you want to know if there are calcifications, you want to see if there are any other findings. So you see all these hyperdensities. How do you know on contrast is not just very, very dense contrast, or is it surgical clips? And sometimes it can be difficult, and not maybe less in this case, but in some cases it can be really difficult to differentiate very dense contrast from the active activation or from bleeding or for anything. So we always need the 3 phases because we want to see how it behaves on the venous phase. So 1 phase is not enough once you have a surgery or some kind of an intervention with the stent graft and all that. Okay, we have post-aortic repair, another is post-surgical case, and we have the coronary images. So the options are aortic graft fold, aortic dissection, intramural hematoma, or no particular finding. I'm showing you again. Anybody can try and guess what it could be? Anyone? Okay. So this is what we call an aortic graft fold, and I will show you why I think it's an aortic graft fold. And I think that it's a fold because first of all, it doesn't look like this a classic dissection. We don't see a force and two lumen here. What we can see is it looks like some of the graft is folding into the aortic lumen, and it is probably a fold. So um, it is usually a common finding on CT angiography, and it could mimic pathology. So it's usually non-pathologic folding or kinking of the graft. Sometimes it can be because of a graft oversizing, or it can happen because of the surgical technique and graft characteristics. And you really have to make sure that it's only a folding and not a pathology because it's easy to confuse it with dissection. Okay, so it's really important to know and recognize this finding. The next case is the patient with chest pain. And I'm gonna show you a coronary CTA. We only see one vessel, and the options are myocardial bridging, coronary dissection, interarterial course of a coronary artery, or no particular finding. I'm gonna show you again. Anybody has any idea? So that is a myocardial bridging because, and I will show you why I think that way. So you see that this is the LED, and you can see, I'm gonna stop the video right in a second. So right here, this is the coronary artery. this hyperdensity here is part of the myocardium. So that is called myocardial bruising when a vessel actually passes through the muscle. Let's get some information about that. So we can see that in 20 to 30% of the adult population, there is a higher frequency in hypertrophic cardiomyopathy. And if you think about it, it makes sense because the septum in this condition is actually thicker. So there are more chances that it will pass through it. It typically happens more often with LAD, commonest location mid LAD. Usually it's asymptomatic, but that depends on how deep that bruising is. So if it's very deep and you have other contributing factors like HOCM, then you can get the ischemia, but it really is not in schedule. The next case also can be because of chest pain, and we can look at the coronary CTA and see if we have an RCA aneurysm, RCA dissection, RCA with intra-arterial course, or no particular finding. I'm showing you again. Any idea? I'm showing you again. Okay, so the correct answer is out there with intra-arterial course. And let's look at the images again. You see that it looks like the ulcer is passing some enhancing structure. And it's probably not the right ventricle, so it had to be the right atrium. It's very difficult to look to see that on this video, but is the condition. And usually, intra-arterial course of RCA is quite uncommon, but it is the most common intracameral course of any coronary artery. Usually, it's asymptomatic because if you think about it, the right atrium doesn't really have a high pressure. So it's like what happened with malignant course between the main pulmonary artery and aorta. But this condition is important to recognize because it is more prone for injury during cut. So it's very important to know that entity. And this patient had a finding of catheterization for further characterization. So let's see what we have here. And I'm showing you the scan. And you can decide if it's myocardial bruising, myocardial split, separate origin of LAD and circumflex, or no particular finding at all. I'm showing you again. Anybody wants to give an answer? Okay. So this is a separate origin of the LAD and circumflex, and let me show you how it looks on the 3D reconstruction. And again, I apologize, everything is upside down. I don't know why it happened. But you can see, for example, on this section, that it looks like the LED and circumflex are coming off from a separate origin on the left coronary sandwich. So the origin is correct, but instead of coming off, instead of having a left main coronary artery, we don't have it, and we have a separate origin. And it is quite a common anomaly, and it is usually benign. Because if both of them come from the left coronary sinus, they just take the usual course and that's it. So it's pretty much fine. But if one of them originates from the right coronary sinus, then it can be a problem, especially if it has a malignant cause. Okay, case number 9, we have a chest pain. So let's see what the finding is. And this can explain the symptoms. So with the RCA originating from the left sinus, coronary dissection, single coronary artery with a malignant RCA, or no particular finding. Showing you again. Anybody wants to try? I'm showing you at a much slower pace. It's a little bit difficult to figure out here what the correct distribution is. But if you look carefully, what happens here, it looks like there's a single trunk. You see this one? It looks like there's a single trunk. It could be either a single trunk coming off the coronary sinus on the left, but I think it's probably a single coronary artery with malignant cause. And why is it a malignant cause? Because if you look carefully, what happens here, I'm gonna stop. So this is the pulmonary trunk, and this is the aorta. You see? So it looks like this is a common trunk. The left main goes on, and the outside crosses between the aorta and the main pulmonary artery. So malignant cause means that the outside can be crossed by the aorta and main pulmonary artery as it crosses over there, and that can predispose for ischemia. So basically, this patient needs to be considered for intervention, and you need to consult the cardiologist and cardiac surgeon because this the next presentation of this patient can be sudden cardiac death, and you want to treat him before that happens. Another patient coming for TAVR evaluation. So let's see what the finding is, and we have the options. No particular finding, ventricular thrombus, VSD, or ASD. Showing you again. So the correct answer is ASD, and I'm gonna show you now. Okay. So this is the left atrium. You see the pulmonary vein going into it. And what happens is that you can see right here in a second. So you can see there's a connection here between the left atrium and the right atrium. You see it's going in. So that is an ASD, okay? I'm not going to say much on this because it's probably something that everybody knows. And this is how it can look on an enhanced scan, but it's very difficult to notice it without contrast. But you can see that it looks like there's some connection between the both atria right here. There's no separation as there usually should be, especially in a person who does have some fat. So if you have a subcutaneous fat, you're supposed to have also epicardial fat. So there was supposed to be some separation here. So that is the axia. Okay. Any other questions? Okay. So let's go on to the next case. The next case will be this one. So we have to decide what the finding is. Is it the autoatrial fistula, autocavalian fistula, left atrial to IVC connection, or no finding? So I'm showing you again. And once more. So the correct answer is left atrial to IVC connection, and let me show you why. So um, if you see, if you look carefully, this is the left atrium, okay? You can see that there's a portion coming from the left atrium, and it goes this way. Follow me. You see here, and again, and it goes into the IVC. This is IVC, right? Because it goes down, and you see that it goes down into the liver, and you can see that there is contrast. But there's contrast because the left atrium sends contrast back into the IVC. So so this can potentially cause lactation because basically we get oxygenated blood from the left atrium, and because the pressure in the pulmonary circulation compared with the systemic circulation is lower, so you can have a shunt. We have another case. The patient is coming with dyspnea, and let's see what the findings can be. What do you see? So we have either biatrial massive with calcifications, chronic thrombi, acute thrombi, or no finding. Anybody wants to answer a question? Okay. So the correct answer is surprise biatrial massive with calcifications. So let's figure out now why it is probably more massive and not thrombi. So, of course, it could be chronic thrombi because they tend to organize and they can calcify just like any chronic process. But usually, when you think about it, chronic thrombus usually tend to organize into the wall and just become more eccentric. So if we think about it, for example, in pulmonary embolus, the same thing happens. So if you have a PE and it stays as chronic PE, usually it becomes eccentric and it organizes. Here instead we have hyperdense masses in both atria and they're calcified. So I think it's less likely a thrombus, even though it's always possible. So let's see what the differential diagnosis is. So it could be the first one, and I will tell you one in a second. So you can have calcified amorphous tumors that are quite rare, non-neoplastic method with calcified deposits, and usually they have a fibrinous material that they can happen in any cardiac chamber. And the fact that we have two similar findings in two cardiac chambers, I think maybe it could come with that. And the patient, it can happen more frequently in advanced renal disease because if you think about it, the failing kidney cannot eliminate a lot of materials it usually needs to. So that is why it could be that way. Cardiac myxoma could happen, and it's indeed more common, and sometimes it can calcify, but usually it comes from the interarterial thrombus septum, which is not what's happening here. And of course, we can talk about thrombi and lipomatous tumors and other primary tumors, but I think these two differential diagnoses are more plausible. Case number 13, a patient who came with a trauma. So let's see what his problem is. And again, it's upside down, and I apologize. So whenever you have a trauma, you always want to look at all the vascular structures. And the most important of all is, of course, the aorta. So question is if we have acute aortic dissection, aortic transection, intramural hematoma, or no finding. Showing you once again. So the answer is transection. And let's see why. So if we look carefully, look at the order. So if we look at the order, first of all, if you have a dissection, as I have already explained, usually, and of course it can depend on the phase, but usually the false lumen enhances differently from the true lumen. Here, on the other hand, you can see that there is an irregularity in the aortic wall. And it looks like there's some kind of a line coming. It looks like it got cut in the middle, and it created all that irregularity. And the two parts look like they enhance similarly, and you have some kind of probably some blood in the surrounding soft tissues. I don't know. I mean, I think it's a computer problem. I don't know why. Anyway, so let's talk about transaction. So transaction, how do we tell the difference? So usually it's complete full thickness tear of the aortic wall, showing a contour disruption and loss of continuity. And usually, as you saw on the video, you can see that it has an irregularity, and that's how it looks like. Usually, at dissection, you have to see the intimal flap. And here, you don't see any intimal flap. So the intimal flap is an essential part of dissection, and it indicates separation of layers because you have one layer that's separated, and that's the intima, and it goes into the lumen of the aorta. And here you don't see it, so that's why it's a transection and not dissection. We have one last case, and that's a finding in the post-surgical assessment of the correction of the tetralogy of Fallot. Let's see. I'm gonna give you a hint. It's probably something congenital and unrelated to the surgery. So the first option is no special finding beyond surgical changes, aortic dissection, left ventricular scar, or persistent left SVC. Anybody has an answer? Okay, so the answer is persistent left SVC. And if you look carefully, you can see that this is the SVC, and this is the SVC, and here you have a left SVC, and you can see that it drained into the left atrium. So now we have a problem because the SVC, and let's see. So persistent left SVC is one of the commonest congenital venous anomalies in the chest. It's about it's not any more than 0.5% of normal population, but it is present in about 5% of patients with congenital heart defects. The vast majority have a normal right-sided SVC as well. and 10% have the isolated persistent left SVC. And the biggest problem is it depends where the blood goes to. So the left SVC can drain either into the left atrium, or more commonly it goes to the coronary sinus. So if it goes to the coronary sinus, it would go into the right atrium in the right direction, because the systemic blood going back into the right atrium where it should go for oxygenation in the lung. But if it goes into the left atrium, so basically we have systemic blood going back into systemic blood, so it will be right to left shunt, because the oxygenated blood goes into the left atrium. So it really depends. So if the shunt is really big, then we can have basically the oxygenated blood and problems because of that. Those are all the cases. Again, I apologize. The cases look a little bit upside down because it's probably some bug in the computer. Um, and that's pretty much it. Thank you so much. Any questions? Okay. Have a
Thank
nice
you.
day, guys. Yeah,
Thank you, Dr. Borosovsky. That was wonderful.
yeah. I'm glad. These are real life cases, and it really helps to see more cases, and the more you see, the faster you actually see them in real life. So it's an, even if you don't remember the case, but you remember that somebody showed you something that somewhere in your brain you will recall it, and you will know how to look for it on Google or anything. But it's important to see that, because that's how you learn. Okay, have a nice day, guys.